కదా ఒక నిమిషం. గుడ్ ఈవినింగ్ సార్. Andarya sir, good evening. Kirit sir,
Good
good
evening, sir.
evening sir. Good evening sir.
Yes, sir.
Good,
Yes,
good
sir.
evening.
Good
Good evening.
Warm welcome to all the faculty. Dr. Advait, can you try sharing your PowerPoint as a trial? We have another 2 more minutes to go.
Yes, sir.
Do you have any challenge, ma? Open the PowerPoint, Advait. Yes, make it full screen.
Visible, sir.
You open the PowerPoint, make it to mix. Go to the slideshow on the top. Fourth menu, slideshow, there is one menu. Thank you. Just run till the end of the slides, ma. Advait, you are able to hear me?
Hello. Yes,
Are
sir.
you able to hear me? No,
Sir, is
don't
the
do other
PPT
things, ma. Just open your
visible?
PowerPoint and keep it open. And just ask you to forward the slides till the
Hello.
end. You remove your headset, Advait. You're not able to hear me, and I'm not able to hear you. Use your computer mic only. That makes life easier.
Just a second.
Are you able to hear us?
Yes, sir.
Okay, all is well. Okay, you can now unshare for a moment. I'll tell you when to share. Good evening, friends. Warm welcome to you for yet another postgraduate clinics. I warmly welcome the senior faculty here, Dr. Hitesh and Dr. Kirit, Dr. Srinivasan sir, and thank you for both the postgraduates joining. Shoshima madam is also here. I expect Dr. Neena ma'am and Dr. Pankaj Modi sir to join in shortly. Thank you, Hitesh sir, for kindly providing the student. Nitin sir, warm welcome to you. Nitin sir is from Nashik, and we are expecting the professor of surgery and surgical gastroenterologist, Priyadarshan from AIMS Hyderabad. He'll be invited guest faculty, and from next week onwards, he'll be joining us as per GAK. Thank you all. We have Dr. Gopalakrishnan. He's the professor of surgery and HOD from Government Velpura Medical College. Anna sir, warm welcome to you, sir. He has kindly permitted Dr. G. Harini to present a case here and Parotid today. So we'll have Dr. Advait to go first. He'll be presenting a case on thyroid nodule. faculty, please take over. Dr. Advait, please introduce yourself, your unit chief, and your head of the department, and start your presentation. Good luck to you, Dr. Advait.
Good evening, everyone. My name is Dr. Advait Kilkar. I am a second year general surgery resident at Narendra Modi Medical College, Ahmedabad. My PG teacher is Dr. Hitesh Andare, sir, and today I will be presenting a case on solitary thyroid node history. A 70-year-old female housewife residing in Ahmedabad, belonging to middle socioeconomic class, came to surgical OPD with chief complaints of swelling over front of neck for 4 months. On elaborating history of presenting illness, the patient was relatively asymptomatic 4 months ago, after which she noticed a single swelling in front of the neck while grooming in front of her. Swelling was insidious in onset, initially 2 by 2 centimeters in size, and gradually progressed to attain the current size of 4 by 5 centimeters. As tested by the patient also has a history of weight loss since the last 4 months. There is no history of any pain over the swelling, fever, no history of sudden increase in size, difficulty to swallow, breathe, or hoarseness of voice. No any history of excessive sweating, diarrhea, constipation, or any history of heat or cold intolerance. No history of tremors, insomnia. No history of change in appetite. Past history. The patient is a known case of hypothyroidism for the past 8 years and is taking thyroid medication, tablet thyroxine, 12.5 micrograms. And there is no any history of similar complaints in past. No history of previous surgery. No any other comorbidities like diabetes, hypertension, TB. No any history of any irradiation in the past. Personal history. The patient consumes vegetarian diet. No history of indicating of excessive iodine intake, no history of excessive consumption of brassica group of vegetables, and the bowel and bladder habits are unaltered. No, the patient is not a smoker or alcoholic. Menstrual history. The patient underwent a hysterectomy 30 years ago due to the complaint of excessive bleeding, and her past menstrual cycles were regular. Family history, no relevant family history. So, in summary, a 70-year-old female came with chief complaint of swelling in front of neck for 4 months, which was insidious in onset, gradually progressive, and not associated with pain, symptoms of hypo or hyperthyroidism, compressive symptoms, or significant family history. So, should I go on with general examination?
Hello? Can you hear me?
Hello.
Hello, Advait, can you hear?
You're
Yes,
audible,
sir.
sir.
Sir, you are audible, sir. You're perfectly
Yeah,
audible. Please go ahead with your
yeah,
question, sir.
yeah. I just wanted to ask him what are the differential diagnosis with such a summary? Do you want to put in the differential diagnosis or will you straight away go with, thyromegaly? Advait?
Yes, sir. So, sir, I couldn't get your question.
So with this
Now,
summary,
would you like to offer a differential diagnosis?
Yeah.
Or going in for straight away for thyromegaly? Is it only thyromegaly or any other differential diagnosis?
So, it is midline swelling, sir. So, it's likely to be thyromegaly because the patient has a history of hypothyroidism. And the differential diagnosis, sir, can be brachial cyst, branchial cyst, thyroglossal fistula.
Is it in the
cervical
midline?
swellings.
What are the midline swellings,
So,
you know?
So midline swellings would be they can be subhyoid bursa, dermoid, thyroglossal cyst, in pool abscess.
Can you go to the first slide, please?
First slide.
Yeah, you come from the history. Sarasast.
Next slide. Next slide, please. Yes. So does the swellings, is it midline or only in the front of the neck?
Swelling is in front of the neck, and further
Why don't you put the
examination, it
picture,
is
Pa?
towards the
Why don't you show the picture
Yes, sir.
so that yes, now you can go back to the your presentation. Sir is asking. Sir, please, sir. Sir was asking,
Hello?
was the swelling in the midline or the front of the neck?
So in front of the neck,
Yes, sir.
towards the side.
You said that thyroglossal cyst, that's why I asked. Is it important to know that swelling started on which side and then it become what size? Initial site of the swelling and the size and shape also, for that matter.
Yes, it is important to know, since if it is
So he
originating from
noticed the 2 into
So-
2 centimeter size swelling where? In front of the neck where? Right side, left side or midline?
left side.
Left side.
Yes, sir.
Okay. And right now you said that it has current size of 4 into 5 centimeters. So is it on the left side, right side, or it is generalized right now?
The left side.
Is it crossing the midline or it is only on the left side?
It is not crossing the midline, sir. It is on the left side.
So what is the significance of this history?
So the significance is that patient has a solitary swelling over the left side of midline in front of neck. So can be either arising from thyroid or any cervical lymph nodes, or it can be a brachial cyst or swelling.
You want to say branchial cyst?
Brachial cyst.
So now you were
Advait?
saying that. Hello.
Yes, sir. Yes, sir. Correct. Carry on.
Yeah,
Continue.
please,
After.
please.
No, I just
You
wanted
can,
to
sir,
ask you.
please.
Yeah. Advait, can it be lipoma of the neck?
Yes, sir. Can be a nice.
So, when you say yes to everything, that means you have to put a diagnosis. I mean, differential diagnosis. So, at the end of your history, if you are asked about like what do you think, so you have to give a broad diagnosis. Although it is a case of thyromegaly only, but then you have to give a broad diagnosis because you have not completed your examination yet. Once you complete your examination, then you can be sure of the diagnosis. No, you haven't carried out step tests, you haven't carried out any deglutition and movement on deglutition. Those things you have not carried out. So till the time you don't know what is it, isn't it? So it can be lymph node mass, maybe lymphoma, maybe anything, right? So that is the thing. So it's kind of an inverted triangle. When you are asked about, what are the possibilities in the at the end of your chief complaints, then you have to give a broad diagnosis because you have not completed the history or examination. Then when at the end of your summary, at the end of your history taking, if you are asked about differential, then you boil it down, and at the end of your examination, still boil it down to one or two. So it's kind of an inverted prism kind of thing, you know. So your answer changes at this what stage you are asked about, what question is asked, right? If you
Yes.
stick to thyromegaly only from beginning, that means you know the case. You have been told about the case. So that's what is not liked by the examiners, isn't it? So you have to keep a broad diagnosis, then
Yes.
go on ruling out the things, and then at the end you come at one particular diagnosis, one or two. right?
Generally, what students make mistakes, they see the case initially and then they take the case. For residents,
Yeah.
they should not see the case first, or maybe they sometimes they examine first and they will take history later. So for
Yeah, yeah.
residents, they should focus on history initially. They should not see the case, because if you look at the patient's neck, then you will come to know that this is thyroid swelling, and you will miss the other differential diagnosis. So always focus on some differential diagnosis before going to the main case also.
Yeah. And meaning the if you tell only one diagnosis from the beginning, that means you have not thought what the examiners are not there to pinpoint a diagnosis, Advait. They are there to have a general knowledge of your analogy, your understanding, your those things they are seeing. So keep a broad thing. Never pinpoint any diagnosis, even if it is like that. Huh? Pinpoint
Making
diagnosis is not required.
making diagnosis is very important, but excluding other differential
Yeah,
diagnosis is
yeah.
also important. So you should exclude why this is not a thyroglossal cyst, why it is not a branchial cyst. You should know the reasons why these differential diagnosis is not in this case.
You have written patient also has history of weight loss since 4 months. So how much weight loss that you have not mentioned?
Patient had approximately 10% weight loss in 4 months.
So what is the current weight? How much amount of weight loss has been there? Is it important to know or not? What is significant weight loss? What do you mean by that?
So when the weight loss occurs about 10% in a span of 6 to 6 months.
In the 6 months. So what is significant weight loss? What is the clinical importance?
So it could can point towards any malignancy or some other pathology.
What is the age of your patient?
70-year-old females.
So 70-year-old, yes, patient can have malignancy and then can be significance of the weight loss. In thyroid swellings, once you are keeping in mind that this is a swelling in front of the neck and it can be a thyroid swelling. So in that case, whenever you mention weight, you have to mention along with it something very important. If a patient has a weight loss despite,
Appetite. Despite
so you always
eating.
have to mention appetite about the thyroid. We are more concerned about the thyroid function. That will give you an indirect clue that patient is having a weight loss despite of normal appetite. So patient has a normal appetite or not?
Yes, sir. Patient has
Normal appetite. Okay, so that point you have missed. Next slide, please. Why you ask for sudden increase in the size of the swelling?
there a sudden increase in size would point towards uh, malignancy, the size of swelling. Either.
Not always malignancy. What actually occurs? Suppose it's a malignancy and patient has sudden increase in the size of the swelling. What is the cause?
There may be stimulation by if the patient is hypothyroid and raised TSH levels are high, then it would stimulate the thyroid follicles and it will lead to more growth of the or hyperplasia of the gland. That would cause a swelling to occur.
So you want to say hyperthyroidism? I think there is some network issue either on my side on your or on your side. I am unable to hear you properly.
Hello.
Uh,
Some disturbance is
Yes,
there.
sir.
Yeah.
Patient is in hyperthyroidism.
Hypothyroidism. Uh, taking thyroid medication, and
How did he elicit? How did he
when
elicit
she
the history?
presented,
How did he elicit the history that the patient is on hypothyroidism?
Yeah.
How did you elicit
the
the history
patient,
that the patient is in
when
hypothyroidism?
she presented, she was on taking a thyroid medication, and previous documents for thyroid values were not available.
Yeah, she was taking
Well,
thyroid medication since 8 months, and your history starts from 4 months saying that
4
the
months.
patient was normal, and she is taking medication since 8 months.
8 years, ma'am.
8 years. So it can never be a past
8 years.
history.
Yeah. 8 years, 8 months, I think so.
Next slide, please.
8 months. Oh, you sent 8 years, you changed it to 8 years, right?
The previous slide, please. See, in how many, why there is a difficulty in swallowing?
Sir, due to the compressive symptoms of thyroid swelling or the esophagus exteriorly, there may be difficulty swallowing dysphagia.
So esophagus is lying quite behind the trachea. So for a thyroid swelling to compress and cause difficulty in swallowing is very, very difficult. And before that, the first thing that you should have been asking is, yes, hoarseness of voice. Then there can be difficulty in breathing. Because there are tracheal rings, patient can have difficulty in breathing, but in very later stage. Next slide. So patient is taking regularly this thyroxine.
Yes, sir. She was regularly taking the medication.
How you came to know that patient is taking thyroxine only?
Did you
On
see the
asking for
medication prescription?
medication, yes, sir. She showed it.
Patient is a literate patient. Literate. She told you that I'm taking
Yes.
thyroxine. And tell her she is taking thyroxine. Okay.
So from
So
history,
for
can you
8
make out?
years, for
Sir,
8 years
please.
she has been taking it. Yes, sir, please.
Yes, sir. Please carry on, sir.
No, for 8 years she has been taking it. Was there any improvement in the 8 years? Or is she still in the same hypothyroidism?
Was there was an improvement, sir, because when she presented to us, her thyroid, she was with thyroid. Her thyroid, her T3 T4 were normal, but sir, her TSH
No,
was
that is
slightly.
later. That is later. That is later. Did she say any improvement in the symptoms after taking thyroxine? From hypothyroid to euthyroid, you said.
Yes.
How do you come to conclusion euthyroid based on the clinical symptoms? The T3, T4 is at the end of the presentation. That means you have seen the reports. That's what we don't want. How do you say the patient is improving? Or
There
is
were
it
no
worsening?
symptoms of improvement in symptoms of hypothyroidism.
What were the presenting
She had
symptoms 8 years ago?
Yes.
What were the presenting symptoms 8 years ago when she was diagnosed as hypothyroidism? And is there any improvement in the symptoms from the time of presentation for the past 8 years? the past history should not be just like this. Is it improving or is it not controlled? So you didn't ask it, isn't it?
The presenting symptoms 8 years ago were lethargy, weight gain, and cold intolerance, but they have improved after the medication.
After the medication, she is active. She's active. She is weight is reduced.
ஒரு டைம் கொடுங்க, 2 நாள் டைம் கொடுங்க, பார்த்து சரியா?
Yes, sir. Please, sir.
Yeah.
Yeah.
Just one more thing, actually. Have you asked about history of retrosternal extension? Because that is again an important history. Probably you have missed it. One thing is, yeah. So I think what is important, I think, is you identify the organ first based on history. That is the first thing you have to do. Next thing is what will be the pathology, whether it's a benign or malignant. And once you do that, then come to the complications, history of complications. And one of them is retrosternal extension. So this way you have to go for the history. You can hear, right?
Somebody, Dr. Manoharan sir, please mute. Dr. Manoharan sir, please mute yourself.
Oh, yes, sir.
Sir, doctor, please, sir, please. Thank you, sir. Kindly mute, sir. Yes, sir. Now we can please, sir.
Yeah. So I was just saying, yeah. Advait?
Yes.
So anywhere in surgery, you have to first identify the organ, which organ it can be, right? Secondly, you have to identify the pathology, whether it's a benign or malignant, and third is the complication. So in that, if you think like this, then you would come to the right diagnosis. So have you asked about retrosternal extension history? How the patient can present? If you are thinking of thyroid, you need to, because that is a very important thing, isn't it? What are the symptoms patient can present? Patient having retrosternal extension?
Sorry, sir. Symptoms of retrosternal extension. So there may be hoarseness of voice. There may be
Hoarseness of voice will come with retrosternal extension.
coughing and
retrosternal extension, what does it compress when it goes to the retrosternum? So that what will be symptoms? Respiratory distress might be there.
the coughing.
You'll have puffiness of the face.
Puffiness, congestion.
Congestion.
Venous.
What do you mean by irradiation in the past? How long ago? And what is the significance? It is a 70-year-old lady, female, isn't it? 70-year aged female.
Yes.
When did you? When do you ask for the irradiation?
Sir, she has ever had any previous malignancy or treatment for it, or in her pediatric malignancy as well. It may
exposure to irradiation and development of thyroid cancer. How long does it take? Exposure to irradiation. After how long does it turn into malignancy? For 70 years from childhood. Sir, please take over, sir.
Next slide. How you can say excessive iodine intake?
Sir, if patient has consumption of more iodized salt or any vegetables that contain excessive iodine or normal amounts of iodine, but if the patient is consuming more,
So you just please tell me whether the patient is taking
Your voice is breaking, sir.
Yeah, what is that?
Your voice is breaking, sir.
Connectivity is the problem.
Yeah, sir, there is some issue with my connection here, sir. I'm trying it, yes, sir.
Madam, any questions in this? Can you go to the next slide, sir? Yes, sir. Rajiv, sir, any questions?
Yeah, you've got a 70 of a lady swelling from not associated with pain. Why do you ask for pain? Gradually progressive, not associated with pain only. What do you mean by associated with pain? Advait?
so to rule out inflammatory changes.
So just pain will
or
rule out inflammatory changes.
if
In summary,
pain,
you have to
fever.
give us the positive and the negatives, which will make sure that your diagnosis, which assures the diagnosis, isn't it? We do you rule out even malignancy here. You've not put anything of malignancy here. Then we are ruling out. You just can't write not associate pain. Why? Why pain? Is it very significant? Are thyroid swellings 90% thyroids, are they painful? They aren't. Hello, Advait? Yeah.
Yes, sir. They are painless.
So, not associated. Had it been associated pain, you would have told me. Not associated pain doesn't mean anything. Symptoms of hypothyroidism, compressive, with no other symptoms. So the patient is just having a swelling, right, in the front of the neck,
Yes.
without any other symptoms. That's it, isn't it?
And he has, sir, weight loss that he has not mentioned here.
Okay. So what do you mean by weight loss in a patient of thyroid? Advait? Hello, are you
So
there?
yes, sir. So
Yeah,
weight
go on.
loss may be due to either hyperthyroidism or malignant
No,
changes.
In thyroid, what is the characteristic of weight loss?
So the weight loss would occur in despite of a normal appetite.
Exactly. So weight loss here, despite a normal appetite, the patient is losing weight. In thyroid malignancy, weight loss is not a very common feature because not associated too much of cachexia, isn't it?
Yes.
Have you seen patients of malignancy of thyroid losing a lot of weight? They don't. You get me? Yeah. You said not excessive
Yes.
brassica family. Why brassica?
So they are cabbage and
Yeah. Why cabbage?
they
What do they
contain
contain?
thiocyanates, so it can
Yeah,
lead
thiocyanate.
to
And what do thiocyanate do?
thiocyanates.
Yeah, what does thiocyanate do?
Uh, Thiocyanate would cause inhibition of iodine uptake, sir.
It causes what is the effect of thiocyanates on
Sir, they would
on
iodine trapping is affected by them, sir, in
is
the
it
thyroid.
trapping? They affect the peroxidase enzyme, right?
Yes, sir.
They affect the peroxidase. Okay, so what do you think
Sir.
this lady is having? What's the size of the swelling?
Sir, at present, currently it is 5 by 4 centimeters.
So you should mention it in a summary. Now. Is it important? Is size important?
Yes, sir.
Why?
So the swelling has increased. It is a
No. What is 5 centimeters? If a swelling is 5 centimeters, and if a swelling is 2 centimeters or 3 centimeters, is there a difference between the two?
yes, sir. There
What?
is a more tissue has been involved.
More tissue.
Perfect.
More than 4 centimeters. If there's a doubt of whether the thing is malignant or not, then more than 4 centimeters, the chances of malignancy increases.
They increase.
Do you get me?
Yes, sir.
Okay, so what do you think is you're dealing with now? Just 4
Sir, it
months,
is a
70-year-old lady swelling in front of neck for 4 months, 5 centimeter. I doubt whether she will come to a surgery OPD. 4 centimeters, 5 centimeters. What's the size? 5 centimeters.
yes, sir.
Maybe, but it is unlikely. A 70-year-old lady will come to your OPD with a 4 or 5 centimeter swelling for last 4 months. She must be having something else.
Yes, sir.
There's no sense of cosmesis here. She's not having any other symptoms. Why should she come to you? So there's something wrong in the history. You're missing some point. Did you ask her why did she come to the hospital?
So she presented for just for the increase in size of the swelling over 4 months.
Okay, unlikely. I mean, okay. So what do you think it is?
So it original diagnosis is solitary benign solitary thyroid nodule.
No. Why are you thinking of just by history can make out solitary?
Sir, there is a single swelling on the left side.
This is. But is solitary thyroid nodules common? Is it common? What is the most common solitary nodule in a thyroid?
There simple colloidal simple colloidal
Thyroid cyst. A thyroid cyst.
thyroid cyst.
That's the most common. Right? Okay. So anyone, I joined late, so I'm not sure about history. But I'll continue with your exam. Continue with the examination now.
Next slide.
Next slide. You
Yeah. General examination. I have examined the patient in proper light and exposure in presence of a female attendant and after taking consent. The patient is conscious, oriented, and moderate built and nourished. Pulse 74 beats per minute. Normal
Okay, Advait, I'll just stop you
character.
here.
No
Advait, I'll stop
radial or
you here.
radial.
Advait, I'll stop you here. All peripheral pulses, radial femoral. Have you ever done it in a thyroid patient? Do you do this in your OPD or even in the ward?
No, sir.
Do you?
Not it.
Tell me. Advait, tell
No,
me.
sir.
Then why you put it in here? Is it going to give you any information? Rather, it tells me that you don't know how to examine a thyroid patient. It tells me that you don't know how to examine a thyroid patient. You're wasting your time in looking for pulses, which is not required here. So I will, if I'm an examiner, I'll cut your marks. Instead of giving you marks, I'm going to correct. Okay, go on.
You have written no specific character. What do you mean by that?
Characterless. Is the pulse characterless?
What you wanted to convey?
Advait ऐसे ही फंसता है आदमी. Students
Yes, sir.
dig their grave in exam because of this. Come bolo, speak less,
Yes, sir.
but speak what is important. That's it. What is relevant. Irrelevant stuff don't give.
Sorry, sir.
Okay, what kind? Sir asked you what kind of pulse will you expect in a case patient of thyroid swelling? Or I say thyroid toxicosis.
Uh,
Go on. You're in which year, Advait? Final year, second year, first year?
Second year.
Second year. Okay. Okay.
Second year, sir.
Yeah, second year. So you're a big man. We're going to be a surgeon next year. Yeah. Yeah. So tell us, what
Yes.
kind of pulse do you expect?
A forceful pulse, sir.
Huh?
Bounding pulse.
Okay. The rate will be increased. There'll be tachycardia in a patient of thyroid. We expect,
Yes.
right?
Yes,
And
sir.
the pulse will be
Tachycardia.
bounding. It will be full, right? Okay, very good. Respiratory temperature. Next thing. Okay. What do we? No eye signs you've done. You can't do eye signs on general examination. These eye signs are very specific for thyroid. Do you get me, Advait?
Yes.
Hello.
Yes, sir.
Yeah. It is.
Yes,
It
sir.
is specific. Yeah, good. Next slide.
Local.
Go on, move.
On inspection, a single 4x4. Sorry, sir. Sorry, sir.
Yeah, go on. Sorry, please. Go on.
A single 4x4 centimeter overt swelling is present over the left side front of neck, extending superiorly up to the lower border of thyroid cartilage.
Advait, I'll
Nearly
stop you here.
2 centimeter above the external end.
Advait, I'll stop you here again.
Yes, sir.
We don't want a GPS of your swelling. Okay? Put a line diagram.
Yes.
Put a line diagram. This is it. Right? 2 centimeter, 3 centimeters above, down, sternomastoid, 2 centimeters medial. Makes no sense here. Yeah, go on.
Sorry, sir. Medially, it is extending up to the midline, and laterally up to the anterior border of sternocleidomastoid muscle on the left side. The swelling has a smooth surface, and the skin over the swelling is normal. There is the swelling moves with on deglutition and does not move on protrusion of tongue. Lower border is visible, and trachea appears to be in midline. There are no scars, sinus, visible pulsation, dilated veins, or no visible lymph node enlargement.
Which lymph node are you looking for? No visible node enlargement? Which node?
Cervical.
Which node?
Cervical lymph node.
So say it. Write it there. Don't assume. I will assume you are looking for inguinal lymph node. So say no other visible swellings in the neck.
Okay.
How can you say? Just say there are no visible swellings, other swelling. There's only single swelling in the neck. There are no other swellings in the neck, right? Okay, go on.
Yes. On palpation, a single smooth surface, non-warm, non-tender, 5 by 1 centimeter
We're
swelling.
not getting a slide. Advait, we're
with
not getting a palpation slide. Advait.
Margins palpable over left anterior triangle of neck.
Advait, son, we are not getting your palpation slide.
Border of
Next slide, please, Advait.
yes. Uh,
Next slide, please.
hello.
Yeah,
Hello.
move.
Visible?
Advait? No, it is not. Sorry, boss. Yeah, that's it. Good. Now.
On palpation, a single ovoid, smooth surfaced, non-warm, non-tender, 4 by 5 by meter swelling is with well-defined margins is palpable in the anterior triangle of neck, extending up to the lower border of left side
We've lost the
sternocleidomastoid
slide,
lateral.
Advait. Dear, we have lost. Yeah.
Hello.
Yeah, go on.
Okay. Yeah.
Make it full screen. Make it full screen.
Make it slideshow. Make it a slideshow,
Yes,
Slideshow from current slide.
See, on the top, you have the slideshow.
Is it hello? Is it visible?
You slide it, but it's not full screen. Slideshow is not there.
Top left.
I think his net is poor. That's why it's delay.
Hello.
Advait, can you make it full screen?
Yes, sir. Hello.
Yeah, please do that.
Yeah. Is it visible?
No. No. Are you using right? No, we've got your mug now.
I will.
Are you on a computer or on a mobile? Advait, are you on a computer or on a mobile?
Computer, sir.
Okay, I think your net is slightly slow, maybe that's why.
Where is that?
You can shut off your video, just keep so that we can save on the bandwidth.
Can you see this slide, sir?
No, it's still loading. Can you do it again?
Yes, sir.
Just stop the screen share and load it again, please.
Is it visible?
Sorry. Oh dear, we lost that also now.
Sorry, sir. Just a second.
No, it's not your fault. Don't say sorry all the time. It's not your fault.
Hotspot on.
No. Is there anyone to help you out? Advait? Advait, you are muted. Advait, are you there?
But I think he has some issues in that sense.
No, he's got his
The network issues. He is trying to take that hotspot from someone.
Okay,
Okay.
we'll wait.
We'll give some a few minutes for him to come in, sir.
Yes, sir.
Hello.
Yeah, good. We can hear you at least now.
Sir,
Yeah,
is it
good, great.
visible
Great,
now?
great. Yeah, great. Palpation. Yeah, good.
Uh, on palpation, a single ovoid, smooth surface, non-warm, non-tender, 4 by 5 by 1 centimeter swelling with well-defined margins is palpable in the left anterior triangle of neck, extending up to the lower border of thyroid cartilage superiorly, anterior border of sternocleidomastoid laterally, and midline medially, and about 2 centimeters above suprasternal notch. The skin of the swelling is normal. The swelling is firm in consistency and mobile in horizontal and vertical plane. Carotid pulsations are felt equally on both sides. Trachea is in midline. Koch's test is negative, and there is no palpable thread. On percussion, there is normal resonant sound over the sternum. Auscultation, no bruise is heard over the superior lobe of thyroid. And on examination of cervical lymph nodes, no palpable cervical lymph nodes are palpable. Systemic examination, the respiratory system, normal vesicular breath sounds are heard, and no added sounds are there. CVS, it is heart sounds are heard, S1 and S2 are heard, no murmurs are heard. Abdomen is soft and non-tender, no organomegaly, and CNS, there is no focal neurological deficit. Provisional diagnosis is benign solitary thyroid nodule.
Okay, let's go to your examination, regional examination. Inspection. Okay, fine. Next. Next, palpation. What do you mean by non-warm? नया term सोच रहा हूँ. Non-warm. Normal. What do you mean by non-warm? There's nothing called non-warm. Normal temperature.
Normal
temperature. You say that the swelling is firm in consistency. What is a thyroid paradox?
Sir, thyroid paradox is when the cystic swelling would be firm in nature and a solid swelling soft on palpation.
Why is that?
It's because the cystic swelling there is more fluid because of the more tension in capsule.
Tension in the capsule. Okay,
it would be
and solid because the vascularity, the cells, it becomes soft. Okay. Could you feel the lower border of the thyroid of this? You've not told me.
Sorry,
can the other any portion of the thyroid be palpated?
Sorry, sir, I couldn't understand. Yes, sir.
Is the thyroid is only the lump palpable, or the any portion of thyroid is also palpable? Is the right lobe palpable? Have you tried to palpate any other lobe?
Or
yes, sir, the other lobes are not palpable. In this, only
mention
the
it. Is it important to mention it?
Yes.
So you have to mention it.
Yes,
Why?
sir.
Why is it important?
Because if the rest of the gland is palpable, it would become a dominant swelling.
Right.
And,
look, your examination is too brief. It is just too brief. Right?
Yes, sir.
You've not told me it. Okay. Next slide.
Sir, just a minute. In that slide, Yes, written the third dimension, that is 1 centimeter. How we could make out 1 centimeter? 4 by 5 by 1 centimeter swelling.
Yeah.
It's on palpation, sir.
No, you can't do the third
There
dimension.
are
Advait.
you can
Yes,
palpate.
you can't.
You
You
can't.
have just give 2 dimensions only that you can palpate. You cannot say third dimension. And one more thing that you have written is reaching up to the anterior border of left sternocleidomastoid. So it ends there or it goes. Is there and what is the
So what is
relationship of
anterior
left
border?
sternocleidomastoid?
Okay, first of all, what is anterior border? What is anterior border?
Anterior border of the muscles, sir.
It is medial and lateral border,
Sorry, sir.
right? There's nothing called anterior border and posterior border.
So what is the relationship of the border and that is medial border of the sternomastoid and the swelling?
So the swelling is reaching up to the medial border of the sternocleidomastoid.
And it ends there.
Yes, sir.
Do you
So
have a
can you make
picture?
out?
Advait, do you have a picture?
So the margin is palpable.
Advait, do you
Sir
have a
is
picture?
Yes, sir is
Do you have a
asking
picture?
picture of the
Yes, sir.
patient.
Just
Yeah, show it to us. That's there. You could feel the lower border margin of this swelling. This is
yes, sir.
right over the clavicle here. It's
Ah.
overhanging.
And what about the relation with the sternomastoid?
Yeah. What?
From
How?
seeing this,
How? Sir, please.
So just a point. From seeing this, we can say that it might be a lymph node only. It cannot be a thyroid swelling above that.
Exactly. How have you concluded this is a thyroid swelling? Just
Sir,
because it's
Quite
moving.
low.
Advait, did you take a video, small video?
Yes, yes, ma'am. Just a second.
Okay. Not. I'm not convinced
Yes.
about the movement on swallowing. Anyway,
Yes,
tell
sir.
us what are
It's not.
the other swellings in the neck which move on deglutition?
Sir, the swellings that move with deglutition
Yeah. Tell us.
are
Tell us
they may
other swellings.
be subthyroglosal cyst,
Okay.
sublingual, submental, then any swelling adherent to the larynx.
No. You tell any swelling means any swelling. What do you mean by any swelling? Tell us the name of the swelling. Which swelling? All those things which are attached to the thyroid or to the muscles or to the thyroid, isn't it? So you have the lymph nodes. They get inflamed when they get attached,
Sir,
isn't it?
yes, sir.
Okay. So anyone?
How
You have
can you
not
say
seen
on
examined
inspection,
the eye signs here. So please.
Advait, how can you say on inspection that the trachea is shifted or not?
Sir, on inspection, the if trachea is shifted, the sternocleidomastoid, the clavicular end of sternocleidomastoid muscle may be raised if it has shifted to the trachea is shifted to that side.
What is that sign called as? What is that sign? That the sternocleidomastoid is more prominent on one side.
So
It's called a trail sign, it is called a trail signs. Okay, tell what are the other ways to tell about the trachea, that what is the position of the trachea? So one is on inspection.
There on palpation, there is a 3-finger test.
Okay.
And a 2-finger test.
Then any other test? You can auscultate, no?
Yes,
Okay,
sir.
auscultation is to be shifted to the other side. So there are 3 ways to tell about whether the trachea is shifted or not. Now, why did you auscultate over the upper pole of the thyroid for the brew? Why do you auscultate in the upper pole?
Because on the upper pole of thyroid, because of the superior thyroid artery being in association with the upper pole of thyroid.
No, but on the inferior side is the inferior thyroid artery. Is that correct statement or not? Am I making a correct statement or not?
No, sir. Inferior thyroid artery would enter in the middle of the gland.
Enters on the lateral side, and it is deeper in situation.
Yes,
superior thyroid is superficial. Well,
superficial.
Inferior thyroid is deep, and that is why you auscultate over the upper pole of the thyroid.
Yes.
Now, what are the things you see in the CNS examination of the thyroid? One, you said that you look for the tremors, you have seen for the eye signs. Any other thing which you have to see in the CNS examination of a thyroid? Advait, can you tell? Are you there?
The orientation, sir. Patients.
Orientation. No, tell about the motor system, tell about the reflexes. All these are the CNS features you have to see. So what will happen in a thyrotoxicosis and what will happen in the hypothyroid?
Sorry, sir.
Do you check for any muscle power?
Deep tendon, so the reflexes would be exaggerated.
Yeah, you see for the reflexes. Yes. Do you see for the muscle power also? Do you check for the muscle power? Which muscle power do you check?
Yes, sir. They would be.
Which muscle power you check?
So
what is proximal myopathy? What do you understand by proximal myopathy?
Muscles in the
So how do you examine for the proximal myopathy?
The patient will have difficulty in performing daily tasks like climbing stairs and standing up from sitting position.
You will not hear standing up from the squatting position, the patient won't be able to get up from the squatting position. Now, what do you see in the carotid pulsation?
Yes,
what are the things you examine in the carotid pulsation?
So the site of the pulse, the nature, if the pulse is palpable,
So you have to see for whether
the
it is
same intensity.
pulsation you are able to
Pulse,
feel,
uh,
and second, whether you are feeling it at the normal place.
yes.
Okay, so these are the two things. If you are not able to feel the carotid pulsations, what is that sign called as? What is that sign called as? Berry's sign, है ना?
I don't know.
Yeah,
Berries.
Berry's sign, है ना? That you are not able to feel in the patients with the malignancy, you are not able to feel the pulsations. But in the case of the big goiter, the carotid pulsation will be displaced. They will be not at its normal place.
Yes.
Okay, so these are the things you have to tell in the carotid pulsation. Okay. So does your patient has got the retrosternal extension or not?
No, sir. The
How can you
lower
say
border
that?
of the gland is the lower inferior border of the uh, swelling was palpable, sir. And the patient did not have any symptoms associated with it.
What are the various types
And
of retrosternal goiter? What are the various types of retrosternal goiter?
So there are 4 types.
What is plunging
It's a
goiter?
plunging goiter.
Yes, what is that?
Plunging in a plunging goiter, the swelling will rise on deglutition uh, and fall again on release.
What are the other findings you will see in a patient with a retrosternal goiter? Apart from the lower pole of the thyroid, what other features will be there?
So the Pemberton's sign would be present, positive.
So what you will see?
Where on raising the hands of the patient on close to the ears, there would be congestion and redness over the face and neck.
If you
Due
see
to
the
compression
prominent
of
veins over that, without
the
even raising the hand, if you see the prominent veins over the chest wall, no, that is suggestive of the patient might be having the retrosternal extension.
yes.
Okay, so what is your diagnosis? Go to your diagnosis now. When you say it's a benign solitary thyroid nodule, what is the differential diagnosis of a solitary thyroid nodule? Let us keep aside benign. What is the differential diagnosis of a solitary thyroid nodule?
Sir, it could be a simple colloidal goiter or a solitary nodule. It could be a toxic nodule, or it could be a neoplastic lesion.
Can it be multinodular goiter or not?
Yes, sir. It can be a multinodular goiter.
And how many
Sometimes
percent of
the
cases of the
other nodules are not palpable and visible.
so in how many percentage of the case of a multinodular goiter that present as a solitary thyroid nodule?
Sorry, sir, I don't.
It's around 50 to 60%. So it's a big number is there. So once there is a solitary thyroid nodule is there, you have to look for the other nodules. Clinically, they may not be palpable, but when you go for the ultrasound, you'll find those nodules in that. Okay. What are the other differential diagnoses apart from colloid, multinodular goiter, and neoplasm? It can be cyst.
Yes, sir. It can be a
It may
cyst.
be inflammatory swelling. Because all are the differential diagnoses. What is incidentaloma? What is incidentaloma?
An incidentaloma is a mass, sir. It is an incidental finding, unanticipated mass seen on imaging, found on imaging. That was
So which is
performed
the,
for an unrelated lesion.
like, can you tell which is the commonest reason where incidentally you can find? Which is the commonest investigation and which is the commonest lesion where you can find the incidentaloma?
Commonest investigations are sonography, ultrasonography.
So when you are doing the patient the color Doppler or the sonography, then you can see, and which is the commonest lesion for which when you are usually getting the incidentaloma?
Sir, nodule, sir, colloid nodule.
No, colloid nodule is for the thyroid. When you are doing the examination of the neck for some other lesion and then you are finding the incidentaloma. So it cannot be thyroid swelling, something else has to be there. It's mainly for the carotids. When you are investigating for the carotid, at that time, incidentally, you find the incidentaloma.
Okay.
Okay, right. So,
Yes.
what is the quadruple test for thyroid? What is
Sir, a
quadruple
test for thyroid is history, sir, history, examination, ultrasonography, and FNAC, sir.
No, history and examination is together. There's a clinical examination, and that is a part of the history. And so that is one. You do the triple test in CA breast, no?
Yes, sir.
So what are those three tests?
In breast, sir, it is history, sir, clinical examination, then histological test and imaging, sir.
And imaging. So here it has to be fourth test. So which is the fourth test? So clinical examination.
Is it radio scanning, sir?
No, the thyroid, you are doing the T3, T4, TSH, So a part of the quadruple test is clinical examination, thyroid function test, imaging, and cytohistology.
Yes.
Okay. Some people, they say that thyroid function test may not be the part of that, but you add the genetic markers in that as a quadruple test. Okay.
Yes.
Right. So how will you investigate this patient?
Sir, I would an ultrasonography, and if on ultrasonography there are then we will go for FNAC.
Are you going to do the thyroid function test or not?
Yes, sir. Thyroid function test.
So tell about that you are going to do the thyroid function test. Yes.
Yes,
so
sir.
how will you say the patient is hypothyroid?
Sir, if the T3, T4 levels are low and TSH level is the patient is in hypothyroidism. So,
No, TSH level is high or low in hypothyroid?
high, sir.
It is high, है ना? So in fact, the TSH is a screening
Yes, sir.
test, है ना? That is the first test which has to be done. And then you go for the free
Yes, sir.
T4 and then you go for the free T3.
First.
In this order, you have to look for the thyroid function test. Okay, then after the thyroid function test, what you will do?
Ultrasonography, sir, of neck.
So when you are doing the ultrasound, what is the frequency of the probe which you are going to use?
Uh,
What is the frequency of the probe which you are going to use?
10,
Hmm?
10 hertz.
When you are doing the
10
abdominal
hertz, sir.
ultrasound, what is the frequency you are using? Hertz or megahertz?
Megahertz.
You calculate in hertz or you calculate megahertz? Megahertz, you know. So when you are doing the abdominal ultrasound, what is the frequency?
Sorry.
When you are doing the abdominal ultrasound, what is the frequency?
Sir, over 20,000 hertz, sir.
No, no. When you're doing the abdominal ultrasound, it is around 3.5 to 5 megahertz. Okay.
Yes.
And when you're doing for the like the breast or the thyroid, what is the frequency which is used?
I don't
It's
know, sir.
around 10 megahertz. You know? It's around 10 megahertz. When you're doing the intraoperative ultrasound or endo US in looking for the CBD and all those, then it is even higher, and it is 15 megahertz. So higher the frequency is there,
Yes.
more is the resolution, lesser is the penetration.
Lesser
Okay,
is
so if you want to have a good resolution, you have to use the higher frequency. And that is why in the case of thyroid and the breast ultrasound, you use around 10 megahertz. Okay, so once
Yes.
you are doing the ultrasound of the neck, what are the things you are going to see and how you are going to report the results?
Uh, for thyroid, sir, we there is thyroid's reading, sir.
Yes. So, what are the various
In
gates in the
thyroid,
thyroid?
sir, there are in thyroids we look for composition, echogenicity, shape, margin, echogenic foci, and according to the findings in composition, it may be cystic, solid, or cystic, spongiform, or solid. And echogenicity may be anechoic, hypoechoic, or very hypoechoic. Shape may be wider than taller or taller than wide, and margins may be smooth, ill-defined, lobulated, or
So, if you say
extra
it's a
thyroid.
thyroids, if
And
it is, you say it is a thyroids 1 is there, what does that mean?
it means that it is a benign swelling, sir. Thyroid 1 is benign, 2 is not suspicious, and 3 would be mildly suspicious, 4 is moderate suspicion, and 5 is highly suspicious or malignant.
Okay. So, has it been done in this patient ultrasound?
Yes, sir.
Just show that. Okay. What else you have to see in the ultrasound of the neck apart from the thyroid?
Sir, the lymph nodes, sir, cervical lymph nodes.
You have to tell about the cervical nodes are there, no?
Yes.
So it's Styrus 2 lesion is there. What does that mean? Styrus 2 means?
It is no risk, less suspicion, sir.
Benign pathology, है ना?
Benign, yes, sir.
Okay. Then what next has been done in this patient?
Sorry, sir.
What other investigation has been done in your patient?
FNAC, sir. Sir, an FNAC has been done.
Okay. So have you done the guided FNAC or unguided FNAC?
The findings were suggestive of follicular nodular disease.
Follicular nodular disease. Okay.
Yes, sir.
So now what is the interpretation of that? If it is a follicular nodular disease is there, should we go ahead with the treatment or should we not go ahead with the treatment now?
Papillary thyroid or follicular adenoma.
When you say it's a follicular nodular disease, what is the chance of malignancy in that?
Malignancy.
The majority of that will be benign one, no? But in the case of the Thyroid 3,
Yes,
if it is the atypical variety is there, then there is more chance of having the malignancy.
Yes.
Okay. Then anything else you want to do? Any other investigation you want to do?
If sir, we can also do a radio if the patient has to look for any cold nodules or hot nodules.
But your patient is hypothyroid, no?
Yes, sir.
So is there any real indication of carrying out the scan in this patient?
No, sir. Not for this
And
patient, sir.
Yeah, and your UAG is showing it is anoic, है anechoic
Yes,
is
sir.
there. So probably there is
Like,
no indication of carrying out the scan in this patient. Okay. So
yes, sir.
so what is the plan?
Since the swelling has increased in size, then we would go for a hemithyroidectomy, sir.
So you want to do a total thyroidectomy or hemithyroidectomy in this patient?
Hemithyroidectomy, sir.
So if you are planning for the surgery in this patient, what investigations you are going to carry
Yes,
out?
sir.
If you are planning for the surgery,
For surgery,
then what are the
yes, sir.
investigations you are going to carry out? Will you do
Sir,
any special investigation in this patient or not?
Thyroid institute. So the calcium levels, sir.
Yes, you can do the calcium level. Yes. Any X-ray you would like to do?
And Yes, sir. The cervical spine, so the lumbar X-ray, cervical spine X-ray. It
Why
may
you want to do the cervical
if the
spine?
swelling may spread to bony to the spine to the skull if it is a malignant swelling, sir.
No, but you are thinking of benign pathology. Why you are going for the malignancy? We are thinking of in the terms of the benign pathology here. You know? So why you do the X-ray of the neck in a case of a surgery for the thyroid?
Understand about it? Okay, sir.
Okay, you are telling the patient is having this problem for last 8 years. You know, she is taking drugs
Yes,
for
sir.
last 8 years. So plain X-ray of the neck will be done for?
I don't know, sir.
You have to see for the tracheomalacia.
Okay.
You know that tracheomalacia has to be seen when you are planning for the thyroid surgery. And that will be also helpful for the anesthetist as well as the surgeon. That where is the trachea, whether it is shifted or not, and whether the lumen of the trachea is adequate or not. So that is why you do the X-ray
Yes,
of the
sir.
cervical spine, X-ray of the neck, both AP and the lateral view. Any other investigation, special
Yes, sir.
investigation you will do when you are planning for the thyroid surgery apart from this? Which is the organ which is at risk when you are carrying out the surgery? Any nerves which are
Sir.
at risk?
Recurrent laryngeal nerve, sir.
So will you like to do anything?
Do an IDLE, sir, the laryngus to check for the vocal cords.
What is the difference
Laryngoscopy,
between
sir,
a
to check.
okay? What is the difference between a direct laryngoscopy and indirect laryngoscopy? What is the difference between a direct laryngoscopy and indirect laryngoscopy? When you examine for this in the ENT examination, you
Yes,
do
sir.
the indirect laryngoscopy. You know how it is done? How you do the indirect laryngoscopy?
So using we use the laryngeal mirror, sir,
Yeah, use the
with an
mirror there,
external.
no? Yes. Yeah, you can use the mirror, but nowadays you
Yes,
can
sir.
have the video laryngoscopy. And direct laryngoscopy is usually done at the time of
Video
the
laryngoscopy, yes.
anesthesia. When he's been anesthetized, at that time you do the direct laryngoscopy. Okay. Anybody else?
Induction.
No. Rajusha, you want to add anything?
Sir, I think we've crossed time.
Yeah, I think we have crossed the time. That's what. Yeah, that's right. Yeah.
Yes, sir. Yes, sir.
Yeah.
Let's take the next.
So, Dr. Kanagal, can we stop here?
सर आप मॉडरेट कर लीजिए सर डॉक्टर खन्ना सर
Yeah.
सर आप मॉडरेट कर दीजिए
Dr. Parmar, you want to ask any question?
No, sir. No, sir. No, sir. We can finish, sir.
Dr.
He-
Susha?
Dr. Advait, do you have any doubts that seems to be clarified, ma? Dr. Advait? All right. Thank you, Advait. You can unshare your presentation. With the permission of the faculty, we move to the next case discussion. Thank you,
Yes,
ma. Thank
please,
you.
sir.
Faculty,
Yes, sir.
Sushma ma'am, other senior, any other questions or comments? Can we move to the next case?
Yes, sir. We can move, please, sir.
All right. Right. All right. Thank you, sir. Thank you. This is Harini. Harini is from Government Villupuram Medical College, somewhere around 150 kilometers down south of Chennai. Kindly contributed by her HOD, Dr. Gopal. And, Harini, please introduce yourself and start your presentation. Faculty, please take over.
Yes, sir. Thank you, sir. I'm Dr. Harini, a final year postgraduate from Government Villupuram Medical College. And under the guidance of my HOD, Dr. Ganesh Kumar, sir, I'm going to present a case on a parotid swelling. Shall we proceed, sir?
Yes, please.
Yes, please.
So,
Make it
at
to
27.
slideshow, doctor. Yeah, good.
Yeah.
To
Oh,
go.
okay, sir. Okay, sir. 27-year-old male from Villupuram who is a daily wager by occupation, belongs to a low socioeconomic status, presented with the complaints of swelling in the left cheek near left ear for the past 3 years, sir. History of presenting illness. The patient was apparently normal before 3 years. Then he noticed swelling in the left side of the cheek near left ear, which was insidious in onset, initially smaller in size, gradually increased in size to attain the present size, not associated with pain, no history of increase in size of swelling while eating, no history of fever, no history of trauma, no history of dryness of mouth or eyes, no history of joint pain, no history of halitosis, no history of difficulty in swallowing, no history of difficulty in opening mouth, no history of difficulty in closing eyes, blowing cheeks, or clenching the tooth. No history of drooling of saliva, no history of loss of weight or loss of appetite, no history of cough with hemoptysis, no history of bone pain, and no history of swelling elsewhere in the body. Coming to the past history, he had no similar complaints in the past. Is not a known case of diabetes mellitus, hypertension, tuberculosis, epilepsy, bronchial asthma, and thyroid disorders. No history of any previous surgeries in the past, and no known drug allergy. No history of previous irradiation to the head and neck region, and no history of previous blood transfusion. Personal history, he consumes mixed diet, is not a smoker, and does not consume alcohol. Family history, no other family members have the similar complaints. Summary is a 27 years old male presented with complaints of swelling in the left cheek near the left ear for the past 3 years, gradually increased in size to attain present size with no other any positive histories, probably a swelling rising from the left parotid of benign etiology.
Yeah, Dr. Harini. Let's
Yes,
go
sir.
to your first slide.
Yes, sir.
Just say swelling in the left parotid region.
Yes, sir.
No left cheek, left ear, doesn't make any sense.
Okay, sir.
Next slide.
Okay, sir. Okay, sir.
3 years notice, okay. Okay, that's fine. Next slide, please.
Sir, just one point
Yes, sir.
that you have not mentioned the size and shape of the swelling, initial and at the present.
Yes, sir. Just mentioned only increase in size. I didn't
No, you have
mention.
to tell us what was the size when he noticed and what's the present size now.
Okay, sir.
The patient will gesture it. Will show you by fingers, okay, it was this big, now it's this big.
Yes,
You can
sir.
see it's big now.
Peanut size or a small lemon size, now it has increased. What was the shape of the swelling? What is
It's
the present
round.
shape of the swelling? Do you know
The
what is
initial.
tumor doubling time? Tumor doubling time?
It's a time record for the tumor to double the size.
So what is the
From
significance?
it's rapid in case of malignancy.
Tumor doubling time is the time taken by the cells to multiply to double size and multiplication.
Okay,
Yes.
sir.
It's not that it correlates with size. It correlates
Okay,
with
sir.
number.
Okay, sir.
Number of cells.
Okay, sir.
Okay. Okay. The next slide, please.
Yes, sir.
Just say no history is suggestive of involvement of patient. No.
Okay, sir. Okay, sir.
Okay. Bone pain. Why do you ask for bone pain?
In case of malignancy, In metastasis. That's why I asked
No,
for both
where
sides.
does, what is the common site for metastasis of thyroid, parotids?
Lung, brain.
Very rare,
Okay, sir.
hardly. This fellow goes locally.
Okay, sir.
Okay, next slide, please.
Why was history of joint pain?
So rule out bone metastasis, sir. No changes. Wait a minute. Yes.
Yeah, next slide. Okay, diabetes and all is medical history. It's not past
Yes.
history. Couldn't be that he's
Okay.
diabetic in the past and not now.
Okay, sir.
Previous surgery, drug allergy, again medical allergy history, irradiation, blood transfusion. Why?
Then maybe an HIV associated parotitis.
HIV associated parotitis. Is it
It's
there?
rare. No, it's rare.
Next slide. Okay, next slide. Next. Okay, so what's the proof? What do you think you're dealing with by history?
It's a benign parotid swelling.
And which is the most common benign parotid swelling?
It's pleomorphic adenomas.
So should we go to the examinations? Anyone?
Yes, sir,
Okay.
please, we can.
Yes, sir. After getting consent, the patient was examined. On examination, the patient was conscious, oriented, and afebrile, well built and nourished. BMI was 25, ECG score was 0, no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, and pedal edema. Vitals, the pulse rate was 80 beats per minute. Blood pressure 110 70 millimeter of mercury. Respiratory rate is 18 per minute, and temperature 98.6 degree Fahrenheit. And proceeding to the local examination, after getting consent, the patient was examined in a well-lit room, exposing the face and neck. Local examination of the left parotid. Inspection, a single globular swelling of size approximately 6 cross 6 centimeter, noted just below and in front of the ear. Sir?
When you are having, the body is bilaterally symmetrical. So
Yes,
you have
sir.
to tell us, first examine the symmetry of the face and
Okay,
say that
sir.
there is a visible swelling compared to the right side.
Asymmetry.
And then
Yes,
just
sir.
don't jump to that side and straight away.
Okay, sir. Okay, sir. Inspection, a single globular swelling of size approximately 6 cross 6 centimeter, noted just below and in front of the ear in the region of left parotid. Skin over the swelling was stretched, no scars, sinus dilated veins, are visible pulsations, well-defined borders. Extent, superior border is 1 centimeter below the tragus, anterior border is 5 centimeter from the angle of mouth, posterior border is 8 centimeter from the occipital protuberance, inferior border is over the angle of mandible.
This is on
There is
inspection.
Yes, sir.
So
158 centimeter.
You've got
Sir, approximately.
So approximately give us the landmarks rather than measurement.
Yeah.
There you're not
Okay,
giving us
sir.
the measurement of the lump, and here you're giving measurements. Just say that it is
Okay,
within the parotid region.
Okay, sir.
Now, what is the parotid region?
It's below, just in front of the ear.
No, there are different landmarks for it.
The retromandibular groove.
No, it's a triangle. It's a rectangle, right? So
Yes,
upper
sir.
is the tragal cartilage, the zygomatic arch, right? Below is the angle of the mandible.
Angle of mandible.
In front, when you draw two
Front
vertical
ramus
lines, one half, when you bisect the zygomatic arch, you bring it down, and the posterior one is vertical through the mastoid.
Mastoid.
That's the parotid region.
Okay.
Right, so just say parotid. Don't give us all this GPS here. Yeah, go on.
And obliteration of retromandibular groove noted. Lifting of earlobe will present. On clenching the teeth, the swelling becomes more prominent, and on opening the mouth, the swelling becomes less prominent. Proceeding to the palpation, there is no warmth, tenderness. All inspector findings were confirmed. A single globular swelling of size, 6 cross 6 centimeters, noted in the region of left parotid. Skin is pinchable, has a bossylated surface, and variable in consistency. It's firm to cystic. The restricted mobility is present. The swelling was freely mobile horizontally but not vertically. The curtain sign is positive. There is no induration of surrounding area. On clenching the teeth, mobility of the swelling is not restricted. And on bimanual palpation of parotid gland, the deep lobe is not enlarged. And on bidigital palpation of the Stenson's duct, the duct was normal. Examination of right parotid and other salivary glands are normal. When patient of examination, he is able to wrinkle forehead, he is able to close the eyes tightly, able to blow cheeks, there's prominent nasolabial fold, and there is no deviation of angle of mouth. Oral cavity examination, there are adequate mouth opening, there is no trismus, no dental caries, no halitosis, uvula in midline, and tonsils is normal. Examination of cervical lymph nodes, no lymph nodes palpable. Other system examination, CVS S1 is still present, respiratory system normal vesicular breath sounds present, and CNS no focal neurological deficit, and perabdomen soft. Diagnosis, it's a case of left parotid tumor involving the superficial lobe of parotid, probably pleomorphic adenoma without facial nerve involvement.
Okay, let's go to your first slide of the plan.
Okay.
Next slide, please. Okay, your lobular observation. Clenching of teeth, the swelling becomes more prominent. What do you
Yes,
mean?
sir.
Bring them up. What does that mean?
It indicates swelling is superficial to the masseter muscle.
Is it important here?
Sir?
Why did you do this? Okay, next slide. Next slide, please. Okay. No, it's fine. Just go back. Just go back. You said curtain sign positive. Just go back.
Yes, sir.
This slide. Yeah. Restriction. Okay. Curtain sign positive. What do you mean by that?
So in case of a parotid swelling, the swelling is not movable behind the zygomatic arch due to the insertion of the parotid fascia to the zygomatic arch. So if any other swelling outside the parotid fascia,
What is the fascia called? Is that deep cervical?
deep cervical fascia, deep cervical fascia, yes, sir.
So suppose it was negative,
Yes, sir.
then what would have happened?
The swelling may arise superficial to that fascia, sir. Might be a lymph node or
Very
any
good,
other
very
swelling.
good.
Yes, sir.
So if this is to distinguish structures below the fascia and above the fascia. Right?
Yes, sir.
Next slide, please.
Yes, sir.
You said variable in consistency. What do you mean by that? In which area, what type of consistency is there?
So in some areas it's firm, in other areas it's cystic, sir. Firm and cystic consistencies noted, sir.
Cystic consistency.
Yes, sir.
Okay. First of all, in your inspection, you've not told us the whether you could see the opening of the parotid duct. What was the condition, right?
Yes, sir.
Inspection is
Yes.
done.
Yes, sir.
Right. Next slide. On palpation, you don't do a bimanual palpation of the parotid. You can't put your hand inside. Never stick your fingers or hands inside the mouth. Please.
Yeah. Okay, sir.
Okay. So it
Okay,
is.
sir.
How do you know that the deep lobe is not enlarged or is enlarged?
On inspection,
Yeah,
the
position
uvula
of the tonsils would be pushed.
being non. Yes, sir.
Okay. Bidigital palpation of the Stenson's duct. Okay,
Yes,
you
sir.
can do it, but
Yes,
because
sir.
there's no history of off and on swelling with related to food, not
No. Okay, sir.
examination right parotid, other salivary glands are normal. Okay, very good. Next
Yes,
slide.
sir.
Able to wrinkle forehead
Yes,
bilaterally,
sir.
unilaterally.
Bilaterally, sir.
So what is the difference between bilateral and unilateral wrinkling of forehead?
So that side of the facial nerve involvement, either
No,
side.
what? Upper motor, lower motor.
Low
How
motor,
is-
sir.
Okay,
In
so how
low
do you
motor,
go on?
sir. In low motor neuron lesion, one half of the face is affected, sir. In case of upper motor neuron lesion, usually the opposite side, the lower half of the face is affected, sir. The wrinkling and the closing of the eyes will be preserved usually.
So very good. Upper motor, because it's got bilateral innervation,
Yes,
above the eyebrows, the wrinkling will be positive, but the opposite side of the face would be affected in upper motor.
yes, sir.
In parrotids, we generally expect a lower motor.
Low motor, yes, sir.
Right? So just say facial nerve functions seem to be intact instead of doing all
Okay.
those various.
Okay, sir.
Next. What is adequate mouth opening?
Is able to pass 3 fingers between the 2 incisors.
Again, 3 fingers. You don't pass 3 fingers.
So, yes, sir.
It is 3 inches.
3 inches, okay, sir.
Right?
Yes, sir.
Christmas. What is Christmas?
Inadequate opening of the mouth.
Christmas is an inadequate.
Yeah.
No, not. So if someone has inadequate opening because of some mucous fibrosis, we'll call it Christmas. Christmas is painful.
Okay, sir.
And when do you get that? In which conditions will you get Christmas?
In case temporomandibular joint arthritis.
Okay, that's one. What else? In
Mm.
parotid.
Any malignant?
Yes, in malignancy.
Malignancy also in inflammatory conditions like parotid abscess.
Right. What else?
Parotitis.
Any other condition which you can think of Christmas? What is lockjaw?
Dislocation of the TMJ.
No, tetanus. Get Christmas. Characteristic.
Okay, sir.
Right. Next slide, please. No lymph nodes. Which lymph nodes are you interested in?
The level 2.
Mental, submandibular.
The upper deep cervical lymph nodes.
Level 2, 3, 4,
2.
5.
Level 2, 3, 4.
Yeah, do that. Next slide, please. You're saying is benign. Obviously, the facial are not involved. Just say probably pleomorphic. That's it. Without facial involvement, not required. So anyone.
Okay.
Harini, this
Sir?
is a short case, right?
Yes, sir. It's a short case. Yes, sir.
So tell us how will you proceed now?
Sir, I would like to proceed with the investigations to confirm my diagnosis. So I'll do ultrasound of the parotid region, followed by FNAC, USG ultrasound guided FNAC.
Why do you want an FNAC?
To confirm it's a benign or a malignancy.
Clinically, you've done any fun of getting?
Yes, sir. Yes, sir.
Clinically, you
Type.
said no, it's benign.
Yes, sir.
Then why do you want to get an FNAC?
Sir, type of tumor.
Okay, tell me the indications for FNAC in case of thyroid, parotid swelling. Look, when you put in a needle, you may damage the nerve, may cause hematoma, may cause seedling, all that kind of stupid things. Okay, so not required.
Sir. Okay, sir.
Even if suppose it is malignant, you would still do a superficial parotidectomy.
Yes.
If it's benign, also you still do a superficial parotidectomy.
Superficial parotid. Yes.
Right. So what's the fun of
Yes.
it? Right.
Yes.
So no FNAC, please. Okay.
Okay, sir.
Yeah. You do an FNAC if it is a recurrent.
Okay, sir.
If you're not sure of your diagnosis.
Okay, sir.
Right?
Okay, sir.
Then you get it done. Okay.
Okay, sir.
So you've done your ultrasound. Now what do you do?
Sir, I will proceed with further investigation to assess the fitness of my patient. And then,
What status? PSC.
sir,
What status do you want to assess?
fitness for surgery,
Okay.
sir. To proceed
Okay.
with
So
superficial
what surgery will you do
parotidectomy.
now? What surgery will you do now?
Superficial parotidectomy, sir, under general anesthesia.
What do you mean by superficial parotid?
Removing only the superficial lobe of the parotid.
What is the superficial
Sir,
over the parotid?
it's present above the facial nerve, sir.
What
The
is the
lobe.
plane?
Facial-venous plane of Patty.
Okay. So you will, why don't you remove the deep lobe? Why do you have to do just a superficial parotid?
So clinically, the deep lobe is not involved. It's a benign tumor, so only superficial parotidectomy is enough.
Oh, why? Because first of all, the deep lobe is much smaller compared to the superficial lobe, isn't it? It's
Yes, sir.
hardly affected,
Yes, sir.
right? It may develop a mixed parotid tumor later on.
Yes, sir.
There's no guarantee that it will not.
Yes,
But
sir.
that can do it then. There's no issue here now, right?
Yes, sir.
Okay. So, what is the incision you make?
And lazy, a modified Blair or lazy is incision, sir.
What is, if there's modified Blair, there must be a Blair's incision also. What is Blair's incision?
Sir, I don't know.
So Blair's incision is the one which is running parallel to the facial lobe. Previously, people used to think that if you give an incision perpendicularly, it will damage the facial nerve,
Okay, sir.
right? So this modification came, right?
Yes, sir.
Okay. So how do you identify the facial nerve now?
The landmarks.
Okay, before that,
Yes, sir.
what is the position of the patient during surgery?
Yes, sir. The patient is in supine position with the sandbag below the shoulder, with neck slightly extended and face turned towards the opposite side, sir.
And what about the head end? Is it raised? Is normal?
No, it should be 10 to 15 degree mildly elevated.
Why?
To avoid the
Why?
congestion, venous congestion.
Very good. And
Yes.
what do you take care while draping the patient?
Make sure to place an iPad and
Do you use an electrical stimulator during surgery?
no, sir, we not follow.
Use
We are
electrical
not using.
stimulator.
No,
Suppose
we
you're
are
going
not
to use
following it.
electrical- So suppose you're going to use it.
Yes, sir. We have to expose all
Care while
the
draping.
muscles innervated by the branches of the facial nerve, sir,
So you'll
during
keep the,
draping. Yeah.
yeah, so you keep the angle of the mouth
Mouth
and the
and then
lip
I.
exposed. Okay, very good.
Yes, sir.
So now you tell me how do you and you avoid a muscle relaxant.
Yes, sir. Yeah.
Now how do you look for the patient now?
And using landmarks, it's inferior medial to the tragus, and Conley's point is the inferior most portion of the cartilageous part of the canal. It's 1.5 centimeter deep and inferior to it, and usually along the posterior belly of the digastric. It's and it's medial to the thyroid process. So these are the landmarks.
Okay, you have the mastoid and the angle between the mastoid and the posterior belly of the digastric.
Digastric, yes, sir.
You have the junction between the cartilaginous and the bony portion.
Bony.
And the phagal cartilage points to. Okay. So when you're doing what does the facial nerve look like? How do you know this fellow is the facial nerve?
No, fibrous band. It will be looking.
So a white structure which is
White structure.
bifurcating.
Yes.
So what are the two branches? One is bifurcating.
Temporofacial and cervicofacial divisions.
Okay. And then it divides into
And temporal facial divides into temporal and zygomatic. Cervicofacial divides into buccal, mandibular, and then cervical.
Okay. So sometimes they both give one branch to form the so buccal, upper and
Yes,
lower.
I see. Upper and lower buccal, sir.
Okay. So you've done the remove the parotid. What about the parotid duct? Do you ligate it? You don't? What do you do?
We don't ligate it in superficial
Why?
paratectomy, sir.
Why?
So it's a deep lobe is intact, it has to
Right.
drain. Yes, sir.
That's it. Okay. Now, what are the complications of parotid?
Flap necrosis, most common complication, and seroma formation, and facial nerve injury, parotid fistula. Yes,
And Frey syndrome.
Frey syndrome. Yes, sir.
So, what is Frey syndrome?
Frey syndrome, it occurs due to the injury of the auriculotemporal nerve. While it regenerates, it apparently innervates the sweat glands and the cutaneous sweat glands, sir. So while salivation, the nerve gets stimulated. The patient, instead of supplying the parotid gland, it supplies the sweat glands. The patient may uh, have a sweating and then redness over that area, sir, and hyperesthesia also.
What is this? What is the starch test? Starch iodine test?
Yes, sir. I have to apply the iodine over the part and have to wait till it dry and then apply starch and ask the patient to, they have to stimulate the salivation. It will turn blue.
Why? Why should it turn blue? Suppose
I
you
don't
sprinkle
know.
it,
Yes, sir.
because it does, there'll be fluid.
Fluid.
Sweating hoga. Sweating means the thing will, the sweat will dissolve the iodine and
Iodine.
starch, and then it will
Yes, sir.
react. They don't react if then when they're dry.
Right.
Need
Okay,
water
sir.
for it, and the water
Okay,
comes
sir.
by the sweat.
Okay, sir.
Okay. So what do you do to prevent sprays?
I have to place a facial or a muscle flap over the parotid bed during surgery, sir.
Now, suppose you injured the facial nerve,
Yes, sir.
right? So
Yes,
how
sir.
do you repair it?
If
What do
we
you do?
can if we can suture it intraoperatively, we can suture it, sir.
So what?
Or else,
Usually the nerve. What is the most important thing which you take care of while switching the nerve?
very
Have
nice.
you read about the difference between switching nerves and tendons? And
No, sir, I don't know.
so you never enter beyond the perineurium.
Okay, sir.
You don't go right through deep, because it will damage the fibrils.
Okay, sir.
Which suture material you will use for nerve suturing? Any idea?
And 90 proline.
Yeah, good.
Yes, sir. Yes, sir.
Okay. Now, suppose the patient develops facial palsy.
Yes, sir.
Okay. Before that, which nerve, which part of the facial nerve is most important to preserve?
Yes, zygomatic branches have to be preserved, sir.
Why?
So if it's damaged, the patient can't close the eyes. It will lead to exposure keratitis, will cause blindness.
Right. Right. Okay. So suppose the patient develops facial palsy
Yes,
the
sir.
next day after 24 hours. What are
Yes,
you going
sir.
to do?
I will start with the patient with steroids, sir.
And
Then and then wait whether it's if it's a neuropraxia, it will recover.
what is neuropraxia? What
It's
is
due to handling the patient may develop palsy, sir. It's not at
stretching
yes, sir.
also?
It's to stretching, yes, sir.
What are the other types of injury of the nerve?
Axonomets, neuronomets. I know.
Okay. So what is
Yes, sir.
axonothomasis? What is neurotomasis? Axontomesis is when the sheath is intact and the axon is gone.
Got okay, sir.
And neurotomesis when the whole nerve is cut.
Gone.
Right. So what happens when there's neurotomesis? What happens to the proximal end? What happens to the distal end? What is Wallerian degeneration? What is Wallerian degeneration?
So I don't know.
Okay, so the nerve, proximal nerve degenerates to the first Ranvi's node. You don't get it here, get it in peripheral nerves, but that's it. Okay, so suppose you've done your next day, you put in steroids, you put in anti-inflammatories. It's almost 2 weeks, 3 weeks that the fellow is not improving.
Yes, sir.
Now what do you do?
If nerve grafting.
You'll do nerve grafting after 2 weeks, 4 weeks. What is the ideal time for nerve graft? Post surgery.
6 weeks. Oh.
At least 3 to 6 months.
3 to 6 months. Okay, sir.
Yeah. So what? Till then the nerve is for 3 to 6 months. If you wait, the nerve is going to shrivel and die. So can you do anything to prevent it?
No.
So you use nerve stimulators to keep it active.
Alive. Okay, sir.
Now during surgery, suppose that you've cut a portion of the nerve.
Yes, sir.
A segment is gone.
Yes, sir.
How do you repair that?
Intraoperatively, can use a graft using greater auricular nerve or sural nerve.
Okay. So there's a special term for this graft. What is this term?
Cable graft.
Cable graft. What is a cable graft?
I don't know, sir. Sorry.
Okay. What's the difference between a wire and a cable? A wire has a single strand.
Single strand. Multiple strands and cables. Yeah.
So here we use two, three small portions of the. You must have seen the picture in Bailey. 2, 3 portions of the nerve, which is attached at the either end, right?
Yes, sir.
Why is that done?
Sir?
Why do you use a cable graft? I just use a single graft. Why do you use a cable graft?
Multiple branches. So.
Yeah, to make sure that
everyone.
All the motor branches are joined. Okay.
Yes, sir.
That's why we put a cable graft.
Okay, sir.
Okay. I think anyone else, sir?
No, sir. Majority has been covered. Khanna, sir.
What is Hamilton belly technique?
Sir, it's a technique used to trace the facial nerve from its branches to divisions. Retrograde tracing of the facial nerve. Sir.
Good. And what is Hopsley technique?
So don't.
The way you drape for the parotid, that is technique is called as the Hopsley technique, where you keep the eyes and the ala open.
Okay, sir.
That is Hopsley technique.
Okay,
and what is House-Brackman classification?
I don't know, sir.
House-Brackman classification for facial nerve. Okay. Grade 1 is it is intact
injury.
facial nerve. And grade 1 is total paralysis is there. You know?
Yes.
So that is the classification for that.
Question.
Now in the patties, how these 3 structures are arranged? Patties
From
plane?
superficial, sir, from superficial to deep, it's facial nerve, retromandibular vein, and then extracarotid artery.
Now tell what are the causes of bilateral parotid swelling?
Infections like paramyxoma virus, tuberculosis, and then Sjogren syndrome, sarcoidosis, and tumors like Warthin tumors may affect bilaterally.
Any other bilateral tumor apart from the Warthin's tumors?
Yes, arsenic cell carcinoma, sir.
Lymphoma.
Lymphoma. Okay, sir. Yes.
Lymphoma.
Yes.
Okay, I think Dr. Rajiv Shah covered everything.
Yes, sir.
Yeah.
Dr. Sushama and others, Dr. Nitin Baste, any comments from your side, sir?
Sir, she spoke very well. We must congratulate her, and
Of
she is
course,
well
sir.
bred.
No, sir,
Yes,
all
thank you,
well.
sir.
She's good. She's good.
Thank you, sir. Thank you. Thank you.
Thank you
Sushama,
very
ma'am?
much, sir.
I think, sir, she was good, and sir, I liked sir's questions. That were good.
Okay. Harini, do you have any doubts to be clarified with the faculty here?
No, sir.
Thank you very much. You just
Thank
note
you,
out
sir.
the few areas you find difficult so that you
Yeah,
go and
sir, I
refresh
noted
your
out.
knowledge. Right.
Sure, sir.
And,
Sure, sir.
thank you to Ganesh, sir, for kindly
Yes, sir.
permitting you. I'll speak to
Thank
him
you,
in
sir.
the morning again.
Okay, sir. Sure, sir. Thank you so
Thank
much,
you,
sir.
sir. Thank you, Doctor.
Thank you, sir.
Well done, Harini. Well.
Thank you,
Just
sir.
only one thing, sir, that a
Yes, sir.
student can hear this episode, and then they can say exactly that what were
Sir,
the
it is
areas they
possible,
were
sir.
wrong.
They can visit
Yes,
the
sir. So
YouTube
that's
channel
why.
and they can.
Yes, that's why I'm asking that the student should just once again see that what are the areas that they might have forgot, but you can again
Yes, sir.
hear so that make out. Yes, because it is available on YouTube.
Yes, sir. Any other doubts or comments, sir? Can we call the session a close, sir?
Yes, connect.
Yes, sir. Please.
Good
Thank
night,
you
sir.
so much.
Thank you, Dr.
Good night,
Harini.
sir.